for me?
Okay, so the first part is the evidence of preparation.
Yep. So I'm washing my hands. We're gonna come in. I'm Christine. I'm your student nurse. We're gonna do a neurological exam on you today. Yeah. Okay. Sorry. Next thing.
Mental status, appearance, posture, body movements, dress, grooming, hygiene.
Perfect.
Behavior, level of cautious, facial expressions, speech, mood, and affect.
So I know in our GI exam, we were like, we're watching the patient's demeanor. But here, it is a much more in-depth. We're looking at different aspects of the patient. Like what the patient, did they come? Do they look like they're in disarray? Is their hair, does it look like it's been groomed? Do they look like they've been washed? Generally things that a person of sound mind, they are upkeeping a certain level of hygiene for themselves. And so we're really noting, we're getting into the nitty gritty of how that patient is presenting for the day. Are they distressed? So we'll go over the first one, appearance. Yes, we're looking like, did they dress? Are they having all their aspects of, like, are all their clothes on them? Grooming, hygiene, like I mentioned, and their pupils, note the size, reaction to light. What do the pupils tell us about a patient? Like right off the bat, if we see a patient who has, say, like pinpoint pupils or dilated pupils. Who said substance use? Great, yep. Substance use is one. Behavior, we kind of want to know how they're acting. So alert, oriented. Right off the bat, if I can say, hey, can you tell me your name and your birthday?
Elena Warren, April 30, 2003.
Okay, so they're aware of self. They know that they are who they are. They know their birthday. And then they're responding to me. So they are, they react to stimuli. They're alert. Facial expression, I'm watching her. You're not presenting like you're, you had a flat face before, but now you're smiling now. Perfect. Yeah, I'm looking at facial expression. Your speech, so when just having her respond to me and they can hear her speech, is her speech forced? Which means, like, is it loud, or is she talking over me every time I try to get a question out? Is it slurred speech? All things that you can kind of start to take note of and break down as you're having this conversation with her. Yeah.
Would we be noting for speech, do we need to verbalize all of that, or are we just saying, like, we note that speech is as expected?
I would like you to verbalize a couple of things in there. Yeah, like speech as expected. I have noticed that we're doing a lot of like as expected, but really I do kind of want to start getting you guys aware of what is as expected. Like what are we hearing for?
I totally agree. We need to know what you think is normal and not. Because let's say she came in and she was really quiet when she was talking. It may be that she has Parkinson's disease, right? So it's really important to listen to not only tone, rate, that sort of thing when you're thinking of speech.
Yeah. Mood and affect. So I know I said when we have patients, especially when we're dealing with patients who are maybe like manic, in a manic phase, sometimes having a patient who looks like they're in there, they're happy to be here, it's just good to start noting that stuff. Sometimes people are just generally relaxed and they're fine, but it can also mean it can have a pathological aspect to it. So we just want to start noting things like that. On the other hand, if they're really flat, monotone, they're not, how do I explain? Like if you have somebody who has schizophrenia or who are like in severe depression, those are things you might be seeing as you're examining and assessing them. So noting for flat affect, or on the other side of things, if they are euphoric. I think that's a word that I saw there. Yep, euphoric, joy, things like that.
The other thing you look for is something that she's doing right now, right? She's moving her feet, she's moving her fingers. Are they fidgeting? Are they bouncing their knee? Are they anxious? Do they have a resting tremor or an action tremor? Those are all things that you want to look for too. Sorry if I'm interrupting.
No, I love it. I really do love it. Please keep doing it. That's good. So cognitive functions, orientation. So again, to person, place, and time. We've already figured out person. She knows who she is. She knows her birthday. Place, time. Now we start asking questions. Okay, can you tell me where you're at?
ISU.
All right, and what time is it? What's the date?
The date, is it the 15th or 16th? I don't know.
It's the 16th.
Thanks.
I have to look.
And I never know what the date is, so maybe using the day of the week sometimes is easier for patients.
Yeah,
Or the
yeah, you
year,
can ask.
Or the year,
Yeah.
who the president is, but sometimes they don't know that either.
And why are you here?
Cargo class.
Gotta go. Paying for it, yep. And so that's your situation. Attention span, can you complete a thought? So a lot of this happens, it's a little bit like very cut and dry, like we're going down the steps, but in an office or when you come into a room to do your head to toe on a patient, you're having conversation with them. You're talking with them. Hey, how did your morning go? Have you seen the doctor yet? Like, you know, things of that nature. And so when we're asking these questions, we're also noting in the back of my mind, man, she seems really like, you know, she's slipping from one conversation to the next. We can't seem to be discussing anything, like we can't follow that thought to the end. Things to just be watching, and that's what that attention span is.
Do you guys know what that's called when you're just jumping, you're going off? Tangential. Yeah, very good. So their speech should be very linear and logical. It follows a natural sequence. It makes sense.
Yeah. Recent memory. So what time did you arrive here today?
6:40.
What?
I get here early.
Oh,
Very
okay.
good. Studier.
Nice. And then we already asked her birthday, which we can check up against the chart, and if they got it right, you've got that remote memory taken care of. So a lot of these things are just grabbed with your conversation as you're going throughout your morning with your patient. Word recall. We're going to give you 4 words, and I'm going to check back in, I think it's no sooner than 5 minutes. What I would suggest for your checkoffs is find a place where that fits down, like maybe make a note somewhere down at the very end to be like, go back and check your word recall, okay? Because we'll have you do that.
We're checking your recall too.
Yeah. I'm like still trying to, okay, I'm
And I
gonna tell
would
you
recommend
4 words.
using easy words that they can remember, like ball, cat,
Apple,
apple, clock.
yeah. Apple, ball, shoe, and cat. Remember those 4 words, and I'm gonna ask you about them later, okay? All right. And then, can you repeat them back to me right now?
Apple, ball, shoe, cat.
Beautiful. And then thought process and perception, do they make sense? Are they aware of reality? Again, overall, as we're talking, what is the sense that you're getting? Cranial nerves. So there's 12 cranial nerves, and we have the supplies to test each one of them. But yeah, olfactory, I've never tested olfactory before in another setting. I'm sure at a neurologist's office, that's probably a place where they will test more in depth. But we've got lemon and vanilla here that you can test. And what I usually do is you just open, and then, can you smell that?
My nose doesn't really work.
It's not really working.
No.
There you go. Test that.
And make sure you ask about allergies, because you don't want to make lemon in front of them if they're allergic.
That's a good note. Yeah, like if the patient is ill or if they've got, oh yeah, allergies in the way of, hey, are you allergic to vanilla? Are you allergic to lemon? But also if they have, you know, hay fever going on right now, that's not a failed olfactory. That's, you've got, your sinuses are not patent. So just keep note of that. Visual acuity, visual fields by confrontation. So we'll go ahead, and then if you'll notice right below that, there's perla. So those are all part of cranial nerve 2. And so what we're gonna do is we'll start with visual acuity by confrontation. And I'm having a moment. Can somebody shout out to me what confrontation is? Can you tell me?
Yeah, so when you're doing a confrontation test, it's actually better to sit at their level. And what you're gonna do is you're going to cover your right eye, okay? And I'm gonna cover my left eye. And what we're testing for is for her to be able to see the different numbers. The best way to do this, because as you look out, your visual field will expand. And so when I'm putting my hands out, I wanna be about halfway in between when I'm doing confrontation. If I put it closer to me, I can see better. If I put it closer to her, she can see better. So we wanna do it at the halfway point at their level. And so you're gonna ask her to say, tell me what numbers you can see. And you can put your fingers up and say, 2, okay? 1, 5, 2. Okay. And then you're gonna ask to switch, so you're gonna cover your other eye and you're gonna do the same thing over here. But it's best if you're both sitting at the same level and then doing it halfway. Any questions about that?
Why do you have to cover your eye?
Because then if you're like way out here and you can't see it either, it's
okay.
right? You know it's normal if you can see it.
Got it.
Well, that's saying if your confrontation's normal.
Got it, okay.
Make sense?
Yes.
Okay.
Thank you.
You bet.
Okay, so we have a lot of different places to access light. You can use your phones, you can use pen lights. I think most of you guys have pen lights. Or we've got our little, we use this for the ears.
Otoscope.
An otoscope, thank you. Also for the eyes, and you just push this little green button down and you twist it on its edge, and most are kind of similar to that. And you just make sure the light's going, and then we're gonna test perla, and pupils are equal, round, and reactive to light and accommodation. So before I even shine this in her eyes, I'm taking note of her pupils, and they are equal, like one is not larger than the other. That's what that means. And then I'm gonna go ahead and shine the light, and I'm looking to see that those pupils are constricting. Good. And then I'm gonna do it one more time. Good. And so they do constrict, both sides constrict.
So what does confrontation mean? So if you are covering up and your pupil constricts on this side, if it's normal, this should also constrict on the other side. That's confrontation.
Oh, okay.
The other thing you can do if you don't have a light, but you want to see if their pupils are going to constrict, you have them look forward at least 10 feet and focus on an object on the wall, and then you bring your finger in close to their eyes, and when they fixate on your finger, their pupils should also constrict.
Thank you. Okay, so then we've got 3, 4, and 6, which is our abducens. And this is the extraocular movement of the eye, the eyeball itself. And so I usually just like to take, we'll use this, but I'm just gonna have you follow this, but keep your head straight, okay? So follow with your eyes. And there's 6 positions. Good. Good. And then I can go forward and back, and I see that those eyes follow.
So an H
And
pattern is best. You're going to go up and out, to the side, down and to the right, up and to the left, and down and to the left. So if you follow in an H, your eyes will naturally do that. And have them only follow the finger. Have your eyes only follow the finger, not your head.
Perfect, yeah. And then something that would be an abnormal is, yes, if they don't follow, or if the eyes start to, if you see nystagmus, is the eye starts to involuntarily like twitch. That would also be an abnormal finding.
Where
Let's
do
see
we
here.
normally see that? What condition where they'll have nystagmus? Does anyone know?
I think there's some if you're intoxicated with alcohol.
Possibly. Vertigo. Yeah.
Vertigo. Vertigo. Oh, nice. Yeah, vertigo.
It's called nystagmus.
Does that happen only when they're having like a vertigo like episode, or if someone has vertigo at
You
all
can
times?
like irritate the eye into vertigo, but also, yeah,
Also in acute care, when your patients are in respiratory failure and they're not compliant with BiPAP and CO2 gets built up, they can't track. So that's a sign that like, hey, maybe we need to get an ABG. You need to be compliant with your BiPAP because your CO2 levels are getting, it causes those cranial nerves 3, 4, and 6 to not track.
beautiful. Thank you. Okay, so we're cranial nerve 5 now. We're going from 6 back to 5. And then we've got teeth clench, light touch of the forehead, cheeks, and chin with a cotton ball. We should have like cotton balls in here. I'm okay if you also use this. You can do that as well. But go ahead and clench your cheeks for me. Good. And then I'm feeling right here too. Clench them. Okay. And I can feel that jaw muscle, the mandibular joint. That's kind of where I'm feeling at. And you can feel that joint right there. And then close it. Go ahead and close your eyes for me. Thank you. Tell me if you can feel this.
Mm-hmm.
Good.
Yep.
Okay, great. And then we're gonna go skip back to 7, face tricks. So go ahead and smile for me and frown. Okay, good job. Okay, lift your eyebrows. Very nice. Show your teeth to me, which you did. Good. And puff your cheeks out. Very nice. And then let's do the whisper test. And so to do that, I'm gonna come behind the patient. And I'm gonna whisper, and you just tell me what I whisper, okay?
Apple. Ball.
The other thing you can do is just use your fingers. You can say, close your eyes and tell me what side you hear my fingers.
And that like little rubbing sound, yeah. 9 and 10, we'll have you go ahead and open your mouth for me and then say ah. Good, and you're watching the uvula, and if it tenses up. And then also speech. So we're just listening for the speech, which we're doing throughout the whole exam. And then we'll go ahead and do 11, which is our shoulder shrug. Shrug your shoulders for me. Good. And tongue tricks. So go ahead and stick your tongue out for me. Oh. Well, first of all, so we're going to stick to the tongue. Stick your tongue out for me. And what we're watching for is if there's a deviation of the tongue to like the right or the left side. And then we have you do, say light, tight, and dynamite.
Light, tight, dynamite.
And then if the sound is clear, which it is. Another way you could test that is if you can just put your hand up against them and you can say press your tongue to your cheek, like that. Other side, good. That's another way to do that. And you feel for weakness if it should be bilaterally equal. All right, motor system, we're checking that next, and we're starting with the gait. So this is an active exam. Go ahead and we'll have you get up, and I'm gonna have you walk 10 feet that way. and then turn around and come back. So I'm just noting how her gait is. Is it rhythmic? Is there shuffling? That's one with Parkinson's. You might see shuffling. If you see short steps or stiff movements, those are things to be noting. We want the gait to be pretty, smooth, rhythmic, and effortless. Coordination, so go ahead and sit down again. We're gonna have you do palm flips. So I'm gonna have you go right here and then back and forth as fast as you can. Good.
What part of the brain is that testing? What function? Does anyone know? So that's testing your cerebellar function.
Okay, good. Okay, finger to nose. So go ahead, and what I'll have you do, close your eyes. Have you done this before?
Yeah.
Very nice, good. And then we're wanting to see that they are actually touching their nose when they do this. I'm like, can I do that? Yeah, I can. And then we'll go ahead and do heel to toe. And so that is, can you remind me, is that this one, or is that walking?
It's just this.
It's like a
That's the
stand-up
walking.
walk,
Okay.
the drunk walk.
Yeah, so I'll have you go stand and then heel to toe, walk this way. Good. And final, I'll have you come back, nice work, and you don't have to walk heel to toe.
Hey guys, make sure when you are asking them to do it, you actually walk alongside of them in case they lose their balance, that they don't fall over and hurt themselves.
That's a really good call out, yeah.
Same thing with
because-
when you're doing the Romberg.
So
And Professor London, I think that you should still
do
show
this.
her. Yes,
Okay, so
please.
we've got the shin. So another test that you can do for motor is when you're sitting, you take your shin and you move it up, good, and back down for both sides. And that's I thought that's what the heel. I don't know why. What is that called? Do you guys know?
It's just
Heel to
called-
shin.
Yeah,
Heel
I'm
to
really
shin.
surprised it was removed because when you're doing your stroke assessments, that's part of your stroke
That's what they do.
assessment. It's a very specific, you test for that when
Yeah.
you're doing your stroke assessment. Can you?
Noting equal bilateral movement, and can
Right.
you actually
Because sometimes,
do it?
with stroke, they lose function.
Yeah.
So I wanna know that my patient can move their heel from their knee to their shin and back. And it's when you do your, there's a specific test you have to take in hospital for your stroke cert. That is part of that, and then when you get your your Q neuro assessments, that's part of the neuro assessment is to do.
Just know it.
So just be aware that it's important to know how to do that and how to do that.
Beautiful.
I don't know if she took these off. She, maybe I'll just wait.
What
I'll
was
just
that?
wait. I'll see what else you're gonna show.
Okay, we're gonna do Romberg next. So to do the Romberg test, we'll have you go ahead and stand. And then, you wanna be close to the patient. And I even hold both arms, cause this one, patient can fall. And so what we do is I have you go ahead and hold your arms up for me and close your eyes.
Forward.
Perfect, yeah.
Okay.
Close your eyes, and then we watch for 20 seconds. And what we're watching for is loss of balance. Good.
And
then,
I even have them cross in front.
Oh, do
with
you
their
cross
feet
in
straight
front?
Together. I mean, you
Okay.
can have them hold out, but I usually
Okay.
do this. If they're already kind of swaying, don't make them do that. They
Yeah.
obviously have problems with their balance, and you're just gonna make it worse. You can also give them I'll let Dr. Esplin, if they're not moving, you can give them a gentle tap.
we push them a little. See how good their balance really is. Yeah. So let's try it. Close your eyes. You've got good steady balance, and then you're gonna wait 20 seconds, and then gentle. Yeah.
Not a full body check.
You can go ahead and say, yeah, I know.
Test cranial nerve 8 as well.
Did I skip 8?
No, it's just
the whisper
Oh, the
test.
whisper
She's
test.
saying that also,
it also
with balance.
Oh, I see. Oh, okay. Beautiful. Then we're moving on to sensory, which is,
So the
yeah,
other things too, sorry.
Oh,
I'm
yeah,
just
go
gonna-
ahead. No, you're fine.
If you're working with a Parkinson's patient, another thing that you might wanna do is finger taps, right? Because your fine motor goes with other motor problems too, and you can also do this as well. If you have someone that comes in and they're maybe detoxing, you can also have them hold up their hands, and when you're tapping, you're looking for them to reflex forward also if they're in active DTRs. And you're also looking for fine tremor at rest, or gross tremor, or also if they're doing movement, that's called action tremor. So look for that too, even though it's not on here.
Okay, so we're moving on to our sensory system. Temperature of skin, superficial sensations. So this is not, what's the temperature of their skin? This is what can they feel? We're wanting to test hot and cold. And then also, we want to do, can they tell for soft and sharp, or light and pain? So I would just grab one of these. I thought I had it open. We'll use this. So go ahead and close your eyes. And I am going to, this is gonna feel soft. So I like to explain what they're feeling beforehand, and then that's sharp, okay? Let me know what you feel when I touch it, okay?
Sharp.
Oh.
I had a moment. Just gonna diagnose soft. Sharp. Soft. Sharp. Soft. Soft. Good.
So just be careful when you do that, you're telling them you're gonna move to the.
Oh, a new place.
Yeah,
That's a
because
good call out, yeah.
if they get scared when you do that, they might kick you, so just be careful.
Yes, yeah.
What are you expecting for us to do for the temperature of skin?
So for the temperature of skin, I don't know that we do actually have. If you've got some cold hands, you can. I don't know that we have for hot.
Oh, that is
Okay,
cool.
there we go.
Tuning fork.
Nice. Okay, for the temperature of skin, we can, let's use the tuning fork to test for cold. We do not have heated things here, so we could just test for cold.
Or you can warm the tuning fork up in your hands and see for a change.
Oh, okay, yeah. Breathe on. Share your moment. Yeah.
We're not doing deep sensations, is that right?
Let's see here. I don't see it on there. No.
Yeah, if you haven't reprinted your thing since like this morning, it's all different.
There's a new one that she brought up. Yeah.
Their stations are back, they took off.
Cool.
Okay, so deep tendon reflexes, that's what the DTR stands for. And so we use this right here to check for deep tendon reflexes. And we'll do biceps and patellar, it looks like, is what they're wanting. So there's a grade scale 0 to 4, and we'll start with the biceps. And so what I like to do is have that person relaxed here, place your thumb down, and then you're gonna hit on top of your thumb. Let's see if I can do it right. Good job. All right, and then this side. Okay, I would say those are about a 2.
And you're actually looking for the contraction of the muscle. You're gonna have them jerk, but you're actually looking for the tendon or the muscle too.
For it to kind of to react to it.
I would encourage you to learn all of the deep tendon reflexes, even though you're going to only be tested now on the biceps and the patellar.
Yeah.
That's really important. You're gonna use that all the time, even if you're not on the neural floor. And that Stanford 25 gives a really good demonstration. I don't ever use a reflex hammer. If you don't have one in your pocket, pocket,
Oh,
her stethoscope
yeah.
works great.
I use my stethoscope a lot. I do, cause you usually just always have your stethoscope around your neck or at your side, but, yeah, so stethoscope works lovely. We like that.
And I don't like those, and you work in ICU, you probably have the round.
We have the round ones.
I forgot what they're called, but they work way better. Don't waste your money buying one of those. If you're gonna buy one, buy the round ones, and I forgot what they're called.
Okay, and then we got our patellar down here, and I just hit directly on the skin.
I agree.
Okay.
So
And
what
some
if she
more
had a
range.
total knee replacement? Are you gonna see a reflex?
No.
No. What if she has not a very good response to you? Does that mean that her reflexes aren't working? What might you try first? So distraction. So what could you tell her to do if you're not getting a good response? Yeah. Good job.
Yeah, that's impressive. That's great. All right, any questions over any of it? Yes.
Professor Hornstein said during lecture that you guys we're randomly going to have to do 2 of the cranial nerves, not all of them.
That's what it said in not the class cafe, but the instructor cafe, where basically it's gonna be like a lottery, we're just gonna have our little thing, and they randomly draw out.
Okay, cool.
You have them use that one printed that says randomly select
Yeah.
two.
Yep. Just
So,
confirming that that's our expectations
Not
for next
having
week.
them test on all of them, we're only having them test on 2 lottery draws.
Well, we had to learn all.
You still have to work
So-
on them, but you don't know what
It's
to
just
do.
learning
You guys-
stuff.
But if you guys are planning on being in the hospital, you should really know all of them. And then touching on reflexes, I know it was removed, but the superficial plantar flexion is really important to know. And that's also known as Babinski. It's where you would take anything really and go up their foot, and it should, like flex. It should flex down, sorry. For expected, and especially in critical care, like your vented patient can still have a stroke. Like you wanna make sure that they have good reflex.
Unless they're a baby.
Unless they're
Yeah,
baby,
opposite.
then it's not, so adult is flex down, a baby is flex back.
Can you just illustrate how you do your stethoscope?
Yeah.
So you do the reflex, cause I'm curious.
So you're gonna find that groove, and it's basically this kind of motion, right? So you're gonna find the groove here. Everyone knows where that is, okay? And then done. Cool. And then for landmarks for your triceps, so you're just gonna, you can have them go like this, and you're gonna hit here, okay? Or you can have them rest at their side and hit back here. If you're doing the Achilles, you're gonna hit on the back of the Achilles tendon back here, and you might need to just hold this and rest it a little bit. If you're not getting a good response there, you can have them lay back and cross this leg across the other one and hit there as well. Okay? And then when you're doing the brachial radialis, you're gonna go right on the tendon. Okay? If you guys want to practice with that later, you can